Sorry about that, guys. We'll go ahead and get started.
Okay, we are doing, can you guys hear me? Okay, we are doing the prenatal genetic screening. So it's me and Laura and Tammy. So the objectives are to discuss what is currently known about the prenatal screening and the client factors that may influence the choice of recommendation, and identify who should be screened and why, and also the risks and benefits of screening, and current recommendation for screening and methods and costs for screening. So the prenatal, what is prenatal genetic screening? So it is the optional test or a group of tests offered during pregnancy or even before pregnancy for the people who are considering to conceive, the couples who are considering to conceive. And it detects the changes in fetus genes and chromosomes before birth, which is dependent on the race, ethnicity, personal history, pedigree, and other factors, and provides information to parents to be about whether fetus has certain genetic disorders like Down syndrome or other Edwards syndrome, etc. And also to estimate the date of delivery through ultrasound. And the conditions that are screened for are specific genetic disorder through family history and pedigree, and also the race, ethnicity, and other factors, and the common fetal trisomies such as Down syndrome, Edwards syndrome, and the cystic fibrosis, spinal muscular atrophy, Tay-Sachs disease, and Fragile X, and risk involved for an adverse pregnancy, just depending on the history, family history, and the personal history of the women, and birth defects including open neural tube defects and microdeletion or duplication syndromes. Incidence and prevalence. So with all pregnancies, there is 3 out of 100 chance for the birth defects or any type of chromosome condition to occur, which is 3%, which is a lot, 3 out of 100 chance. And the leading cause of infant deaths are congenital malformation, deformities, and chromosomal abnormalities. And the second one is disorders related to short gestation and low birth weight. And 1 in every 33 babies are affected with birth defects in the United States. And 20% of the infant deaths are caused by the birth defects, which can be prevented or managed if we do the prenatal genetic screening. Congenital heart defects affect about 1% of births per year in the United States. And the most common chromosomal disorder is Down syndrome. About 1 in 700 babies are affected by Down syndrome. And about 3 pregnancies in every 10,000 have anencephaly. And each year, about 1,500 babies are born with spina bifida, which can be detected with the prenatal genetic screening. So the factors that influence the recommendation, so gender, female, and personal values and beliefs. So what are they gonna do with the result? Do they have plan, or are they gonna manage, or are they just gonna worry about or do nothing? So the personal values and belief affect the recommendation. And also the family and the personal history, as we talked about last week, which is very important. So if the family has any genetic problems, or if the baby might have the high chances of getting those problems, and also the personal history of the mother, and also the previous history of birth, miscarriages, or other birth defects. And race and ethnicity. So certain race and ethnic group have high chances of having some of the genetic problems and disorders. And also the risk factors involves like the maternal age or the family history, if the mom is less than 20 or more than 35-year-old, and also the pregnancy, which part of the pregnancy she is in, first trimester, second trimester, and also with the Down syndrome, it is useful to do the test before 20 weeks of pregnancy. And also the maternal age, so 20 years, between 20 and 35. And if the mother is less than 20 and greater than 35, they have high chances of having those genetic problems. So who should be screened and why? All reproductive age couple who is to conceive, again, it's optional. No one has to do the test if they don't want to. And also the pregnant couples, and couples with family history of genetic disorders and birth defects. So they have high chances of having those problems and defects again with this pregnancy. So couples with family history, and women with family history of Fragile X, and couples of Ashkenazi Jewish ancestry. So there are a list of disorders and problems that are prevalent in this group of population. It's listed in our book. And also couples from certain race and ethnicity for common disorders prevalent in that ethnic group, such as African, Mediterranean, Southeast Asian, have the high chances of having hemoglobinopathies. So they can be screened for those. And women with previous history of birth defects and miscarriages, and also the maternal age, as we have talked about earlier, younger than 20 and 35 years and older. And women who is concerned and worried, if they are concerned and worried about their pregnancies or regarding their age or their family history, so they can be screened. So the benefits: discover conditions that may impact future pregnancies, and also to manage those pregnancies. If you want to plan for the pregnancy, or like in the rural community, they can go somewhere where there is good facility for the babies and also the mom, and also to manage the pregnancy and determine the potential outcome. With the positive result, they can manage their pregnancy if they want to continue the pregnancy, or how they want to get the information, be ready for the pregnancy. And if it's negative, they don't have to worry anything about that. And also for the plan for a complication at birth and after baby is born, looking for the information, finding the support groups, and being knowledgeable about the disease and everything, and helps to make informed decision. And the risk of miscarriage with invasive testing like the amniocentesis, there is the risk for miscarriage. And also the emotional and financial consequences, like people may feel angry, guilty, or anxious about the result. And also certain tests can reveal the family history, the history about the other family members, which may not want to share the information, so that can be a social problem. And also the financial consequences, like the health insurance and the work leave and everything, there's a financial consequences, and false positives or negatives can be frustrating and make people worry too. And some of these tests might be against the religious or the personal belief of the person.
Okay, so moving on to current recommendations for genetic screenings. I just want to kind of preface this section by saying that recommendations are kind of different across the board depending on what agency you're looking at. There's differences in national guidelines from like ACOG to the American College of Medical Genetics. And so you kind of have to base your choices on, I guess, who you want to follow. There wasn't a whole lot of consistency out there. Everyone kind of has a different idea. As far as like a practice guideline, I found something on National Guideline Clearinghouse which discussed prenatal screening and diagnostic testing options for chromosome aneuploidy. And what they recommend basically is that providers should offer options of maternal serum screening and diagnostic testing for chromosome aneuploidy to every patient basically, and that they should engage in discussion with patients about benefits, limitations, risks, etc. So it's kind of just a broad recommendation. There's not specific recommendations for each one of these tests that I'm going to go over. So these are very specific, and we're starting with preconception screening at the top here for Fragile X, which is an X-linked disorder, and the test that they would do for that would be a Fragile X mental retardation 1 DNA test. And screening for this is recommended, carrier screening for people who have history in their family of Fragile X, or also people who have kind of an unexplained developmental disability, even if they've never been diagnosed with Fragile X. Sometimes also women with elevated FSH levels of unknown cause. That was brought by Abrams as a risk factor or someone you might want to screen. And according to them, they also recommended general population screening. So as I said, it's kind of different across the board who would actually recommend that. But according to this author, they did suggest that. As you can see, sensitivity and specificity for this test is really high. All right, continuing on with another choice for preconception screening. So for spinal muscular atrophy, or SMA, they would do a PCR restriction enzyme digestion analysis for detection of SMN1 deletion. And so the American College of Medical Genetics recommends for this, again, population-based SMA carrier screening. This is something you can offer to people, and specifically screening for members of an affected family, somebody who has it in their history. Positive carrier screening of parents. So if you had a mom or dad that tested positive as a carrier, you would then want to do prenatal screening of that baby. Sensitivity and specificity of this test are also very high, so that can certainly influence recommendations with a patient. Another preconception screening that is available is the one for cystic fibrosis. This tends to be one that is offered quite often and is recommended for all women of reproductive age, regardless of their ancestry. This is done through a CF mutation panel, which basically covers 23 known disease-associated mutations. There are larger panels which cover a whole bunch of other additional mutations. However, individuals with family history of CF, partners of those mutation carriers, and persons who have CF might require those more extensive, larger panels. Just in general population, you could definitely use the 23 mutation panel, and that would be sufficient to start with. And sensitivity and specificity on this test is also very high. A couple of others, these are more specific to people of specific heritage. So Tay-Sachs disease is more common in the Ashkenazi Jew heritage, and also I found in a lot of research that I had done, French Canadian populations can be more prone to this. So you would want to screen your patient to see what their heritage or what their background is, and then offer this as an option. It's performed with a molecular analysis with a DNA-based test, also a biochemical analysis for the hexaneamidase, or both. You can do both of those as well. And again, sensitivity and specificity are very high according to ARUP for that test. For sickle cell disease, we know that African heritage is very prominent for a sickle cell, and so you want to keep that in mind when you are offering this test. And the preferred test for this is hemoglobin electrophoresis combined with a CBC, because that combination will test for both abnormal S and C hemoglobin. And then the final preconception screening that we did specifically indicate was alpha and beta thalassemias. So this is similar to your sickle cell disease in that it's the hemoglobin problem, and it's recommended for individuals with African heritage, but also, as Kanti was talking about, family heritage of Mediterranean ancestry, Southeast Asia, China, India, Pakistan, and even the Philippines. So that's kind of a broader base of people, a population that we should be considering. And in this testing, a CBC is usually performed initially, and then if that's abnormal, a hemoglobin electrophoresis and serum ferritin can be added to further kind of diagnose that. Sensitivity and specificity a little bit lower on this, but still worthwhile to do that test if you think someone's at risk. Okay, so as we know, out in the world of GYN care, fetal aneuploidy or Down syndrome, so trisomy 21, trisomy 13, and 18, these are focused on an awful lot because certainly they are more prominent than the other types of genetic disorders that happen. And so this specific screening should be offered to all women regardless of their age or background. And what I found in my research was there's a ton of different screens that you can do for this particular group of disorders. However, the most accurate was the integrated screening, which is combined first and second trimester screening. So first trimester, that patient would have a nuchal cord translucency measurement with ultrasound. So they're just looking on ultrasound kind of at the back of the baby's neck. There's like a fluid-filled sac, and that's what they're measuring. And also at that time, they would do a serum analyte measurement, so a free beta HCG, total HCG, and a pregnancy-associated plasma protein, or PAPA. So that's first trimester. Then going on into the second trimester, they're going to do an additional test, which is a quad screen. And so it's a serum screen again, which will do free total HCG, PAPA, alpha-fetoprotein, and inhibin A. And they recommend that you do this during 16 to 18 weeks gestation to optimize screening for neural tube defects. This was all put out by ACOG in a practice bulletin this year. And those results are then combined from first and second trimester, and they're provided as a single result to that patient after the second testing has been done. The accuracy on this was significantly higher than some of the other screens. They have single screens. There's a pentascreen. There's all different kinds of screenings that you can do for this. But this particular one tended to have the most accurate result. Laura. Thank you. Non-invasive testing, so there's two modes of screening for these genetic abnormalities. One of them is non-invasive, which is what we've been talking about with the serum screening test. This, of course, can be maternal through the mother, or you can also do paternal serum screening tests, and with ultrasound as well. Uh-oh.
Sorry, guys, I lost connection, I guess. Let me get this back up on the screen. Sorry. Let me hold on. Get back over to Tammy, do you know which slide we were on?
Modes of screening.
Okay, thank you.
Yep.
One sec. Oh, screen that. Share it.
Thank you.
Can you guys see my screen?
Yep.
All right.
Okay. So I can't remember where I was, but ultrasound would be your other option for non-invasive testing. And then invasive testing, which usually would be offered to people who have extremely high risk or based on some types of serum screening, they may decide to do these. So chorionic villus sampling, which is performed at 10 to 14 weeks gestation, and also amniocentesis, which can be offered anytime after 15 to 16 weeks gestation. You don't want to do it too early because the risk is a lot higher, but you don't want to wait too late. So, or it's better to do it during that time period for safety. And both of these, of course, have risks involved because they are invasive for sure. Okay, so alternatives to screening, obviously doing no screening. This would be decided upon based on a careful conversation with your patient and family partners, whoever might be part of that decision-making process. There is option for newer methods of screening for fetal aneuploidy that I did find out there, which is cell-free DNA screening. And for the trisomy 21, sensitivity and specificity are right up close to 100, and but also high for the other trisomies as well as the sex chromosome aneuploidy. The significant factor with this specific type of screening is that positive predictive values were 50% less in general obstetric populations than in high-risk populations. So that's something to think about when you offer that. And I think it's a little bit more expensive right now, although the pricing probably will come down. So decision-making tools, how do you help an individual or a couple determine their risk? As Conti said, you definitely want to obtain a family health history, including their ethnic background. And this might be something that they're going to have to do some work to get that information. With that information, you're going to form a pedigree, like we talked about last week with Carrie Guy. And based on that, you're going to determine more specific risks and go forward by discussing risks and benefits of the screening, et cetera, and then planning for a course of action based on risks as well as whatever positive or negative results you may determine through that screening. So costs of screening tests, this is something that I tried to find more specific numbers on, and believe me, I researched a lot, but I couldn't find a specific cost on each one of those screening tests. Costs look to vary, according to NIH, from $100 up to $2,000, and that's going to depend on the company you use, what type of insurance you have, and what type of screening you're doing. Whether it has to be sent out, that type of thing. So I did speak with GYN Clinic here in town, and there are a lot of companies on the market. The ones that they specifically used here in Cheyenne was the company called Natera, and this test they use is called Panorama, and what that tests for is trisomies, sex chromosome abnormalities, microdeletions, triploidy, and gender reporting. So you would also find out the sex of your baby. There's a website there and a phone number listed for them. And then the other company that they used was called Sequenom, and they have a test called Maternity 21, and that tests for the trisomies 21, 18, and 13. And both of these websites had just a vast amount of information on them, not only about the screening tests that they offer, but options and different educational tools that you can use with your patients, and genetic counseling. So the numbers listed on the screen can get you to someone who can get you to a counselor if you need that type of thing. And what do you do if your patient doesn't want screening? I think it's important certainly to respect the decision that your patient and their partner or family is making. You want to make sure that you have information that you can answer any questions that they might have as they're coming up, and continue to provide ongoing support of their decision. If they just decide they have more questions and they call, be available to help them try to make those decisions. And if their risks are elevated and you feel there's a great concern and they don't really feel comfortable going forward with any testing, you certainly could refer them to a genetic counselor to try to get a little further education and support from those folks.
All right. So we then went into kind of the special considerations when you're working with different groups of folks. Considerations for diversity would be other than Caucasian ethnicity and other minority groups, single parents that are deciding that they want to try to have a child via artificial insemination, the GLBT couples, cultural practices that might be different, and then ensuring that the client has privacy throughout this whole decision-making process. So screening forms should include inclusive language, just like all of our other screening forms within the office. Don't assume that you are working with a heterosexual couple, and the provider should be open to cultural traditions that might come through in the deciding of whether or not to do genetic testing. If a partner is present, the partner should be involved in the decision making as well. And also consider language barriers that could occur as well. Just back to there was not that much research on special populations or diversity in screening. It is much less likely that somebody who is African American or Asian would have genetic screening. Part of that is the counselors, genetic counselors, are underrepresentative of the diversity in our population. And so sometimes that can be scary to try to walk in and get genetic counseling from somebody who you might feel might not understand your culture or your where your heritage has come from. And so I think that there's definitely a race difference in how screening goes, and that was brought through the research as well. And there will be a call for genetic counselors and diversity in recruiting as well. Financial considerations, does the insurance cover the test or some of the testing? Does the patient want to pay out of pocket for the testing because they do not want their insurance company to know? And then concerns for future issues with the pre-existing conditions. Would just knowing increase their risk for privacy exposure by telling somebody on accident at work, or just knowing, does that make it harder for the client? So here were some resources that we found online. So Making Sense of Your Genes, a guide for genetic counseling, was great. And that was on the NIH website, and it kind of gives a general layman's terms for basically what we've gone through in our talk so far. And then the National Society for Genetic Counselors, as this would be maybe more for providers, but there is a cost for using this as providers. So you would have to join the society as well. And then the National Institute for Health also has a general like genetics home reference guide for providers to use. So we have a role play case study. So Miss Stephanie Bascom is a 37-year-old woman that arrives today with her partner of 6 years and spouse of 1 year, Jane Stevens. She is in today to talk about genetic testing and inquire about genetic counseling for an artificial insemination planned pregnancy. They have had one visit with a different primary care team, but we're concerned about the treatment that they received in the first visit. Miss Bascom and Miss Stevens are hoping to establish care with a provider that is willing to consider their cultural and relationship differences. All right. Hello, my name is Laura, and I'll be the nurse practitioner working with you today. It looks like you came in to discuss your plans for a future baby and talk about possible considerations and concerns related to artificial insemination and genetics. Is this correct?
Yeah, we've heard a lot about genetic testing, and I do have some family health concerns in my family's history.
I appreciate being a part of this visit. I can't have my baby of my own because of my own health problems, but it is important for us to have these conversations and really understand our risks.
Great. Thank you again for coming in for the visit. Congratulations on your goals to becoming parents. It is truly an exciting time. Although I am not a genetic counselor, I will be able to help you get started in thinking about genetics and family planning. If you decide to move forward with the attempt to become pregnant, we will definitely move forward with getting you in touch with a genetic counselor.
Thank you.
Let's start with your family history, Stephanie. Is that okay?
Sure.
Do your siblings have any health concerns?
Well, my brother is healthy with 2 healthy children. My sister has high blood pressure. She has 2 daughters. One of them is healthy, but the other was born with cystic fibrosis.
Do you have any other siblings?
No, I don't.
Do your parents have any health concerns?
My dad had a heart attack when he was 40, but ever since then he's been healthy. My mom's never been sick, but she did have a sister that died when she was 4 of complications of cystic fibrosis.
Thank you for sharing this information. I'm noticing there's an incident of recurrent generations with cystic fibrosis in your family. Do you know if your sister was tested for being a CF carrier when her daughter was diagnosed?
She did get tested, and she is a carrier of the disease. Does that mean that I'm a carrier and I have to get tested too?
It is possible that you could be a carrier, but is not given. There is testing that can be completed to determine if you are a carrier. The other option would be to test the sperm as well that you are going to use for your insemination to see if they're a carrier. We can also do a pedigree. I'm going to try to share my pedigree for you guys. Here we go. So we have our patient here with our arrow. And then we have her sister and her husband would be 2 carriers since her sister didn't have CF. Then we have her child that was affected. We don't really know about the dad's history, so we don't know if he was a carrier as well, but we do know that the mother of the client had a sister with the disease that passed away, which would imply that her parents were likely both carriers of the disease and had a child with the disease. There are a lot of other ways that this could go, but for doing a quick draft at the during the visit, this would kind of show you, is our patient at risk? Would she potentially want further testing? And so we tried to use the pedigree as just a quick way to say, you know what, maybe she should get some testing done if she wants to. All right. Do you think that being a carrier would change your mind on whether or not to move forward with pursuing the pregnancy, Stephanie?
I'm not sure. I see how much pain and how much effort my sister goes through in caring for her daughter. I can't imagine life without her, though. It's kind of a tough decision.
I think that it should be something that we have a little more time to think about it. We don't have to make a decision today.
I agree. There is no need to rush if you need more time to think about the implications of genetic testing.
I do have a few questions about genetic testing after we become pregnant.
Sure. What questions do you have?
I know that we are a little bit on the older side and that having a baby later in years can put babies at risk for abnormalities. I'm just curious what would be the recommended genetic testing for us?
That is an excellent question. In general, 4 in 100 births are affected by defect or chromosomal abnormality. Oftentimes, there is no way to predict this, but it can be detected through testing during pregnancy.
Would Stephanie have to go get the testing completed?
That is entirely a personal decision, but it could be something to consider if you plan to move forward with the pregnancy and with the family history of children with special needs.
Thank you for the information. I have never thought about it in much depth.
I think we have a lot to think about. I think I'd prefer to have a meeting with a genetic counselor prior to deciding to move forward with our own pregnancy.
It can be a lot when reviewing all of the information that goes into genetics. Let me get some further information on who to call, and we will also have the office staff look into whether your insurance offers free genetic counseling by phone.
I really appreciate the time you spent with us, and reviewing the pedigree chart was helpful in visualizing our risks. Thank you again for your time.
So we did find some resources that you can call to in Wyoming. The Wyoming Health Department actually does maternal and child health unit testing on a regional setting. And so you can go to their website and find the dates throughout the state. And you can also give a call. Carly is the one that sets up the counseling session. So you could always give a call over to her as well. If you were talking about other genetic counseling that's related to cancer, it does look like they do have genetic counseling for cancer up in Casper as well. So genetic counseling and testing need to be personalized to each client and situation. Considerations for cultural, sexual orientation, inclusive language, and ethnicity should be handled with sensitivity and an open mind by the provider. It is important to have resources available for the client to be counseled prior to and following any testing to promote positive outcomes of the testing. And then here are our references. Do we have any questions, comments?
I'll make a comment just to start conversation. You guys, I love your case study because I feel like, so I'm in an OBGYN office, as you guys know, and so I've heard some of these conversations happen between my preceptor and a patient. And I feel like a lot of patients think that when they offer genetic testing, that they're almost implying, like, would you want to do this because if we find out, you know, it's about terming a pregnancy or something like that. We see patients who are, I've seen it mostly with patients who are already pregnant, but the thought is no, it's not only about that, and it's about, you know, you could plan for certain things, or it's not like there's other options, you know, I guess what I'm saying is providing that doing the genetic testing because it would be a decision on whether only keeping the pregnancy or not. It's about, I mean, patients can plan and just have this information, you know, to go forward with the pregnancy. And so I guess that kind of came to my mind during the case study.
Well, and certainly when you think about, Monica, a place like Torrington or a lot of our rural areas in Wyoming, it's important to know if you might have a baby that has severe disabilities when they're born, because the resources you have in a place like Torrington or, there's a lot of small places that have tiny hospitals. You have a lot less resources for infant care there than what you would say in a bigger place. So knowing, then you could go on to a bigger facility where you've got those resources.
Yeah. And I think I've just seen, some good conversations about, it just opens up, a world of other things to consider. It's not necessarily about only, keeping a pregnancy or not. And I've just seen patients immediately when they say, do you want to do some genetic testing for this or that? And they're like, oh, no. And then I've just seen them kind of, provide some education about why we can do it and stuff. And I think it's easy, for patients not to really understand, some of the reasons why we would conduct some genetic testing.
Mm-hmm.
I just wanted to add on to Tammy's statements, and I guess Monica's as well. In my experience, in Denver, we'll receive a lot of the babies that are born in kind of these rural areas of Wyoming. And in my experience, the babies who, the prenatal care wasn't obtained and we get the babies, things are really bad. But if we get these high-risk babies or these high-risk mothers before, and we have a maternal transfer instead of an infant transfer, everything goes so much more smooth, and the complications are decreased and then some. So I find it super interesting on Tammy's statements on how this is just really aspect of preparing the family so that they can, in these rural places of Wyoming, can get the help that they need for that child and for that mother, depending on the complications that might coincide these results or whatnot. So it's really, like you're saying, Monica, this is not about not having the baby, it's just preparing for the baby that's going to come. So I appreciate that.
So, Dana, when I was pregnant with my daughter, just a quick story. I was in labor what seemed like forever, weeks and weeks and weeks, and I was rotating between a MAG and a terbutaline drip. And the doctors finally came in and said, we're going to do an amnio, because they couldn't figure out why she kept trying to come. And so they were convinced there was something severely wrong with her. And it's kind of crazy to think, because she was born, it'll be 16 years ago in 14 days. But on November 11th of 16 years ago, I had an amnio done, and she was born 5 days later, and I got the amnio results in the mail 6 days after she was born. So it's like, I don't know if it was more for the doctors. It didn't matter to me what was wrong with her. I was going to have her and do whatever I could for as long as I could. But it was kind of weird to think that this is what they were searching for. And by the time I got the results, I already had her. So it was kind of interesting. And so sometimes it works out like that for the best. But it's terrifying when you're waiting for those results. And then we were lucky because we got early reprieve because she was born and she was perfect. So anyway.
That's it.
I want to throw out there one of the things that happens with screening. When you compare screening to diagnosis, when you're screening, doing the quad screen or the early first trimester or second trimester integrated screen or the cell-free DNA screens, these are screens. So when you have a patient get these results back, this isn't diagnosing that this child has a problem. So then you deal with the anxiety, the worry, all of the other things that go along with waiting to find out, well, what do we do next? So maybe a little discussion about that. How would you deal with that?
Actually, somebody that I took care of, or I can't remember what the circumstance was, but somebody that I was recently talking to in the last few days had this happen, where they had a positive screen came back, and for months were worried and, you know, fretting about the baby that was going to be not how they wanted it to be. And then their baby ended up being completely healthy and had no problems whatsoever. So I think probably prefacing the fact that you're going to offer these tests to them with, you know, none of these are 100% accurate. They're not diagnostic, as you say, but this can give us an idea of something that might be an abnormality that we need to prepare for, and kind of letting them know that that it's not going to ever be 100%, and letting them kind of decide from there. Because a lot of people, I know when I was pregnant, I didn't want to know. I mean, I didn't care because I would have just had the baby regardless, and kind of dealt with it as it came. But I think that's the choice that a lot of people will make based on, well, if it's not really going to be 100%, maybe I don't want to do it. But they definitely need to know that there's some uncertainty with the results of those tests.
I think too that it's just important. So screening is definitely an option to the mother, and we have to think about those psychological components. That I know my mom was into her 30s and she said, no, I don't want screening, which I probably would do the same thing. But the emphasis I do want to put on is the prenatal care and getting ultrasounds. If they don't want screening and they're in a high risk population, or maybe they're advanced maternal age, or they have some kind of genetic predisposition for for some kind of disease, congenital disease, I think that's when we open the door up. Then I would highly recommend, you know, you continuing your prenatal care and getting timely ultrasounds, so that way we can avoid complications. However, screening, we know that there are a lot of instances where there's false positives, and that just brings on this worry beyond belief, which I can completely understand. I don't know how to avoid that necessarily than just keeping full disclosure and transparency about how this is not diagnostic and that it can be wrong.
And I think, as just like with any other testing in healthcare, that there is often the idea that only one test is going to be completely definitive for an outcome. And I think it's important to look at the entire picture. So you look at, are there more than one chamber? Are the chambers connected in the heart? Are there 4 chambers or not 4 chambers in the ultrasound? What's kind of going on with things? And then deciding, you know what, we could do some testing from here. We don't necessarily have to start off with the testing. So letting them know that it's not like, okay, we found out that you are 4 weeks pregnant and we need to make sure that you get all of your testing done, but to also let them know these are options that we can kind of look at as you would like to. So you don't have to decide today, you don't have to decide tomorrow, and you may never ever have the testing done, but to at least have the conversation and leave it open and say, you know what, you don't have to make that decision today, I think is super helpful for clients.
Go ahead, Monica. It's okay.
Oh, I was just going to add on to that there, I completely agree. But there are instances when it is based off of timing in the pregnancy. And so depending on when you see them, they may have to make a decision, you know, within a certain amount of time. Just as you guys talked about the timing of some of the screening, and I've seen this in clinic. Just you know, you have a little bit of time, but in order to make it the most accurate, we need to make a decision by the certain times. I don't know. Just thought I'd add that in there.
Right. I guess I was talking about the optimal patient that comes in and it wants to have all the prenatal care.
Yeah, no, it's tough. We just had someone come in who thought they were 8 weeks pregnant, but couldn't remember their last menstrual period. And so we did an ultrasound for gestational age and turned out she was 20 weeks pregnant. And so we were like, oh, okay, so this changes everything. But yeah, so, and I mean, that's a, did I just, I thought my internet went out. But yeah, it's tricky. And I agree with, you know, full disclosure, you know, the possibility that there's false positives and the fact that it could inflict a lot of anxiety and worry. There's some people that would prefer to do it just to maybe get rid of some of the anxiety and worry. But yeah, it's tough because it is a totally personal decision. And something that we have to, as providers, just support whichever way they want to go.
Maybe if we could have a little discussion of like the ethics of this. One of the things that when I was doing more prenatal care would come up a lot was patients would ask if this was covered under their insurance or if Medicaid covered it. I had a lot of Medicaid OB patients, and it was covered under Medicaid, and that would influence their decision to get this testing done. If they didn't have insurance, many would opt not to because it was too expensive. Can we have a little discussion about the ethics of, you know, access to this type of testing or screening?
I think a lot of that came out in my research when it had to do with like minorities not getting and that it might not be offered to them in the same way that it's offered to other clients because maybe the provider thinks, oh, they don't have the insurance coverage that I expect, so I'm not even going to offer it to them. And so I think it's important to keep that in mind, is to offer general advisement to everybody instead of just specific groups and that type of thing. And I think, like you said, if it is covered by Medicaid or not, you still have to cover it with everybody.
Yeah, and emergency Medicaid doesn't pay for this. These are, you know, clients that are undocumented, only have access to just the rudimentary prenatal lab, and that's it. This is not covered under that. So, you know, the access to care issue or ethics of who we offer this to and who we don't, I think is huge. The other ethical question is, one of the things that, and I don't know if it came up in I can't recall if it came up in any of the ethics articles I gave you last week, but providers have been sued for wrongful life for not offering these tests, not offering screening for Down syndrome or for, the early prenatal screens, or genetic testing for cystic fibrosis and other things. And some of those suits have been won because there isn't any documentation that any of this testing was offered. And part of that was probably didn't get in the history that possibly they needed to do that, or we just weren't paying attention. So that does come up as well.
Esther, do you know if clinics typically have a form that a mom or a family would sign if they decide not to do genetic testing? I did see that in some of my articles where you would want to document that you offered it, you know, but I would think that you'd have a form maybe that people would sign.
That is coming in some places. It used to be just on the ACOG form that you would check off any family history of certain problems like, you know, Fragile X, thalassemias, those kinds of things. But yeah, and I don't know in my prenatal care setting at CU, since I don't do much prenatal care anymore, if that's done, if something's signed. But yes, that you have to document somewhere that you did offer testing. Because people have won these suits wrongfully.
So I have a question then, Esther. Where does that fit into like the primary care setting? Because where I'm at with my clinical this semester, we've had I think like 3 gals come in for a pregnancy test, confirm pregnancy, and then it's a pretty quick appointment. My preceptor discussed a little bit of prenatal care, what medications to stop taking, what she should start doing, and then just refers her off to an OB. So if that's the most you do as far as prenatal care, is that initial like, yes, you're pregnant, yay, if you're happy, and then send them off. Is that at that initial appointment, should you start discussing that, or is that more like that the OB deals with that? What's our responsibility?
I know I kind of had a feeling this would come up just because a lot of people aren't doing prenatal care. Monica, having the opportunity to do some prenatal care in Torrington is a bit unusual, honestly, doing some of your rotations. And it is getting very specialized, and probably for good reason that it gets specialized. For this reason, one of the good reasons, that this really does get thoroughly fleshed out. You may never encounter this in your future in primary care unless you do prenatal care. I think one of the things, and Conti and I have had this come up like 2 weeks in a row now, with patients coming in with unusual genetic histories into our little reproductive health clinic. Not for those problems, but getting a history on these folks and having some of these genetic questions come up, I think has been really interesting. And I think Conti probably can speak to this a bit more, how much this has impacted maybe what you're getting in terms of a family history. I think people to think about it too is important.
Yeah, I was going to add that not just with the pregnant women, just asking history to everyone. And if you see any problem with their family history and the pedigree, we can recommend them for the genetic counselor or what they can do the next. We can give them options that can be helpful for the reproductive age women, or to anyone with the breast cancer, ovary cancer, other cancers, or any of the genetic problems.
And I think too, sometimes a patient or client might bring something up, Annalise, because they're used to you're their primary care. And so they might bring up the fact that they want genetic testing or something about their history because they feel comfortable with you versus somebody else. So they might bring it up because I think it is kind of a hot topic, genetic testing and that type of thing. So they could bring it up and then you would have to deal with it maybe a little bit, but just to have like an idea of the basics, to be like, this is what they'll probably talk to you about, even if you don't do any of it yourself, to just be like, have an understanding of what goes on, I guess.
You're right. We did actually see that a little bit too. We had a girl come in, she was establishing care, about to leave to go on a honeymoon. And she had mentioned just kind of like briefly, she's like, we are thinking about getting pregnant right now, maybe in the next year or so. But I guess her brother had just recently been diagnosed with a very mild form of CF that they had never caught, that it affected his seminiferous vesicles. I don't know. It just affected different, pretty ambiguous areas. And so they just found that out. So she was asking us, what would I need to do if, I want to make sure, my husband and I want to get tested before, see if we're carriers before we get pregnant. So that, what I thought was interesting too is that, I guess, as far as genetic counseling goes in Saratoga, they refer everybody over to Colorado. And she let her know, she's like, if that's something you want to think about, I would tell you to start thinking about it now, because it's taking a year plus to get in for counseling and to actually get genetic testing done. That's how backed up they are in Colorado. And so she was telling us, she's like, if you think you want to get pregnant in the next year, I would start taking the steps to get on that list now, because it could easily be a year or more before you actually get results, which I thought was interesting.
Just for the rural Wyoming folks, they offer genetic testing up here through a telehealth thing. So like at the clinic I'm at, I know it's the main and I want to say only OBGYN clinic in this area, which is why we get such a plethora of patients from a huge surrounding area with lots of different problems and stuff. I'm actually in Scottsbluff, Nebraska is where the clinic's at. And so anyways, though, every patient gets offered genetic testing that comes in for prenatal care or even for GYN care. My preceptor offers it to almost everyone. She feels very passionate about offering the service, but they can actually get it through telehealth. So I don't know if anyone else is in a rural area, but I'm not exactly sure where the genetic counselors are physically at. I want to say maybe they were in Colorado.
Yeah, Wyoming contracts because we don't have those services in Wyoming. The Department of Health contracts with Colorado to have those services accessible, and it's usually through Children's Hospital for child genetic counseling, as well as Anschutz Cancer Center for cancer genetic testing. But one of the things in this scenario, and I think this was, I don't know if this was a same-sex couple with looking into getting pregnant. One of the things that does happen with sperm donation is some genetic testing, not on necessarily the sperm that may be coming, and it may be available in certain sperm banks. The genetic testing is actually done on these donors. But generally, some genetic testing is done in fertility clinics to, you want to improve your odds as much as you can that this pregnancy will be, have a positive outcome, that they will actually get pregnant. So a lot of genetic testing is done in infertility clinics. CF is one reason. You guys have run it. We'll get into that when we get into infertility in men. But one of the other options for families like this or couples is egg donation. And those folks that have undergone egg donation often have had genetic testing to also improve the odds that you're not going to have a carrier issue happen. And that's an option for families like this that do have genetic problems in the family that maybe are either not compatible with life or long-term chronic problems. But that also brings up other ethics of eugenics and there's a new case out where a couple has this baby I think it's in utero right now, 2 mothers, a mitochondrial DNA from 2 moms, where they've actually genetically engineered what's going on with that fetus to prevent a genetic disorder from occurring. That's a huge, enormous thing that I think your generation of providers is going to deal with more and more and more and more. And what are the limits of this? What can we actually prevent and not? So I think you're going to encounter a lot more of these ethical questions coming up. What do we do with all this information? And one of the other things in the years of practice in OB, we've taken the wonder out of pregnancy almost entirely. There's nobody doesn't, they're very rare that you have people that don't know what they're having. When they do have ultrasounds, like in Denver, these ultrasounds, they look at everything. They know how many chambers, they know how many fingers, they know everything. I have not delivered a baby with a genetic or congenital anomaly that we didn't know about in a very, very long time. And that's another issue. I think that we've just completely made this a science project, unfortunately. But that's another discussion altogether.
In our working on the project, on a presentation, Conti and Tammy and I were like, gosh, like, would we want all of this stuff done? It puts like so much more into things, and being a provider, going from being a nurse to a provider, and the considerations are so different than they were before. And so I think we were also thought it was very interesting. Like, it'll be interesting to see where all of this goes. And it kind of leaves an uneasy feeling in the pit of my stomach of like, oh, where is this going?
I think it's important to remember that ethical dilemma and that line that we draw is very personal to each person. I know that I'll have to put my biases aside whenever I'm talking to patients about these things, because I might be more conservative in some aspects and then more liberal in others, given my experience in the NICU. Yeah, it's super ethical. There's a lot of ethical dilemmas with all of it.
No, and I use this screening test for a reason. I know that many of you pointed out, you may not get the opportunity to actually discuss this with clients, but this touches on a lot of issues, ethical issues, eugenic issues, social and political, and all sorts of other issues. I had an instance several years ago that when we weren't doing prenatal screening as readily as we are now, that I had a couple that they were both older, family history of PKU. They had 3 children already with PKU, and their 4th baby was an oops. They decided not to do any genetic testing at all in terms of prenatal screening. I'm sorry, not genetic testing, but prenatal screening. And this baby had a cystic hygroma. And we noted that on an ultrasound at 18 weeks. And they opted to terminate. But in hindsight, I kind of wish we'd gone back to, really talking about prenatal screening earlier. This was, and it's not an easy decision at any point in pregnancy to opt to terminate, but at 18 weeks, it was a completely different situation altogether. We had to refer them out to, tertiary care center because that's not done in Wyoming. So lots and lots of issues with us. So that was a powerful lesson for me. I wish in hindsight I'd had offered, we'd done a better job of discussing that at the beginning of the prenatal visits.
I'm just curious, was that, so that kind of thing, is that what would that be picked up on in screening?
When cystic hygroma would have probably been picked up as it's like a form of spina bifida, where the spinal cord just doesn't form at the top. That baby would have been anencephalic. Its brain was forming in a sac. What brain it had. Lower brain stem was forming in this sac in the back of the head. And it's not compatible with life. And rather than going through the entire pregnancy, up to term, they opted to terminate at 18 weeks. And it actually turned out to be closer to 22 by the time we got it all arranged. To have them go down to Denver. So it's difficult, very difficult. And it would have been picked up probably in that early first, at that time it would have been the quad screen. We didn't have the integrated screen at that time. And then that probably wouldn't have been picked up till about 16 weeks at that time. So, because you can't do the AFP, you don't get the AFP. The AFP isn't accurate until 16 weeks for spina bifida or alpha fetoprotein. probably more than you guys wanted to know, but.
No, thanks for sharing that, Esther. Like, it puts perspective on some of these tests.
Really.
So I actually really appreciate the experience. And
My biggest frustration with it was patients that said, "Does it get paid for? And do you know what you want to do because you can get paid for? Let's have a discussion about what we're actually looking into here." But now more and more, the more we know about genetics, the more access we have to more genetic testing. I think the more we have to be sure that we're getting all the information we can about family genetic history, and offering what is available out there. And as Carrie pointed out, there are very few genetic counselors. I think Denver Children's only has 2. And then, geneticists, MD geneticists, but the counseling piece of it's really tough. It's tough to get people in to get this done. We've created a need that we can't fill. Well, great discussion, guys. And it is recorded. We've totally figured this out now. So I will put this in your course shell. Be looking for towards the end of next week, over the weekend, I'll send out the scenario for the on-campus standardized patient. So be watching on the on 5872. I'll give that to Candy to put up. And then I'll also put up a scheduler, like we did, similar to what we did in 5825, in your calendar that you can sign up for a slot for your standardized patient. Any questions from any of the other talks or any of the quizzes, or will I have you here for a few more minutes?
Can I ask about the willow ceremony?
Sure.
I was just wondering, is that geared more towards the second year? I think we're just, well, I am, and I know a couple others are a little confused on like what it is, or in like if it's required, and like what we do or what we.
It really is geared. It is geared for you guys. It's kind of like your white coat ceremony. Kind of giving you the step into your new realm of your new career. I would direct questions regarding, is it required, those kinds of things, to Anne Marie. She's the one that's organizing the willow ceremony. That's why we have you coming on campus the night before. So it's a really nice. It's a nice thing. We don't do the white coat ceremony like, pharmacy and medicine, and for reasons that you will learn at the willow ceremony. But if specific questions regarding it, I would email Anne Marie.
Okay. I just didn't know if it was like geared towards the second year students or the third year students.
We used to have everybody come.
Oh, okay.
But we've made it more specific. We've quit trying to do that because it's too hard for everybody to get here. But I would direct those questions to Anne Marie. Okay? Sorry, couldn't answer that one fully.
That's fine. I'm planning on going anyways. I was just kind of more curious about it.
Okay. All right. Any other questions regarding the readings and anything like that? Are you having any trouble accessing the e-textbook in co-library, or have you had a chance to do that yet? Let me know if you're having any trouble with that. There really are no good textbooks, great textbooks out there for male health. And that's, I guess, a good example of why we're doing maybe a poor job of providing good men's health and wellness. It's all directed at the lower half of their body, so it's interesting. Okay, well, I will let you go, and we'll see you again next week.